Thank you for joining the National Headache Foundation's Pediatric Headache webinar. We are joined this evening by Dr. Shannon Babineau of the Neurology and Pediatric faculty at Mount Sinai School of Medicine. Dr. Babineau is a board-certified headache medicine and pediatric neurology. Dr. Babineau, thank you for joining us.
Thank you for having me. So what I'm going to talk today about is really just a basic overview of how I approach headaches in children, some basics about just kind of things to think about in diagnosis, as well as some things as far as management and treatment and those kinds of things. And then hopefully we can get into more detail with specific questions that you guys have. So what I wanted to start with was just mentioning how common headaches are in children. And if you look at kids that are under the age of 18, up to 50% of them have had some form of recurrent headache. So at whatever point in their life where they're taking these surveys, they report that they've had headaches at least every couple of months, if not more frequently than that. And as you can see right below, they talk about how kids can have up to 6% of them, which is a pretty large number, can have daily or near daily headaches. So these are really intrusive into children's lives, and I think that it's really important to recognize the amount of impact that this can have. Not only is it causing the child to miss school, which is of course the most important thing that their focus should be on during the day, but it's also causing missed work for caregivers that have to stay at home with them or take them to doctor's visits. Is causing missed social activities, both in school, socializing with their peers, as well as after school, weekends, things like birthday parties, other kinds of events that are important in children's lives, and can also cause missed extracurricular activities, things like sporting events, participating in after school band, and other things that they want to do. So these really can have a significant impact in their child's life. Some of the causes of headache, kind of as an overview, a broad range of stuff can cause headache in children. The most common thing is some kind of systemic viral infection, meaning that they have the flu, they have a cold, and on top of that they'll get a headache. And it's not necessarily because they have an infection in their brain, in their nervous system, but just the stress of the infection that they have either in their throat or their ears or their nose is enough to cause a headache. So by far, when you see kids in the emergency room or in the general pediatrician's office, that's the most common reason a child has a headache. Once you get into kids that have more recurrent headaches, so some of those other kids we were talking about, the up to 50%, next most likely thing is probably they have some kind of primary headache syndrome. And when we were talking about primary headache syndromes, these are things that we think are kind of part of you, you're born with. The most common primary headache syndromes are migraine or tension headache, which most people are familiar with. Next after that, I would say a fair number of children have headaches because of some form of head injury, some type of concussion. Certainly this stuff has become more popular in the news these days, and I think we are becoming, as healthcare practitioners as well as parents, more aware of the gravity and the seriousness of having a concussion. And certainly headaches can be a large part of post-concussive syndrome, so you always want to be mindful of that. If a concussion has been, if your child has had a concussion, something I always ask about to see when the headache started. Now there are, of course, rare causes. These are the things I think people come to me a lot worried that this is what it is, although they, to find this often happens less than 1% of the time. But things like infections in the nervous system, these are things like meningitis, a tumor, bleeding in the head, seizures, or things like increased pressure. So those are there, that's what we're looking for, but those are extremely rare causes for children to have headaches. So what do we do? What do you do when you come to see me, or what are the important things to know if your child is complaining of a headache? First and foremost, you want to have them seen by someone, and it's important that they have a good neurologic exam. What we're looking for are any of those worrisome signs that would trigger off in our mind that one of those bad things at that bottom of that last slide's list was going to be there. So what we're focusing on is, are all the parts of their neurologic system working correctly? After we do the evaluation, some other possible things, and oftentimes what parents are interested in, is whether we need to do a picture of their child's head. This is talking about things like CAT scans or MRIs. In general, most of the time when we go through, if there's not anything concerning or worrisome in the discussion or anything on the exam, we often don't need to do any type of picture. But there are cases where we think it's important. And so listed kind of below are some of the more important reasons. So if you have a very young child under the age of 6, typically we think about it. It's not an absolute, but I think that people get a little bit more nervous in younger children. If the headache is located in the back of the head, that again also is potentially a worrisome sign. If there's no real family history of headaches, so again, these primary headache syndromes, migraine and tension headache, tend to run in families. And so if you've got a child and no one in the family has ever really had headaches, that also kind of raises a little bit of an eyebrow. If the headaches are new, they've never had headaches before, they've come on suddenly, or of course, like I was talking about, there's something unusual on the neurologic exam. And typically the test that we're talking about is an MRI. In the choice between doing an MRI and a CAT scan, the big difference is that the CAT scans are, they're great fast tests. They can be done in under 5 minutes, but they're not very sensitive. They don't show as much detail of the brain, and when we're looking at the brain, we really like to see as much detail as possible, so we like to do MRIs. The other big benefit to MRIs over CAT scans is there's no radiation, and particularly in children, we're worried about radiation exposure. So I really try to prefer using MRIs when we can, if that's what we decide needs to happen. I'm sorry. So why is it so hard to identify children with headaches, and why is this something that is often missed? Children are often, we're now kind of moving into migraine. Children often don't fit the standard criteria that we use to identify migraine. There's also a lot of misconceptions kind of in the general public as well as in healthcare providers that migraine doesn't happen to children, or that if it happens in children, it's not necessary to treat it. But the truth is that migraines do happen in children. Up to 10% of girls and 5% of boys have migraine. And in the reverse, if you ask people that have migraine in adulthood, greater than half of them will say that their onset happened before they were age 20, and 12%, which is a pretty significant number, say that prior to age 7 their headache started. So these are things that happen when, that have happened since childhood. There are, a rarer population, but still a real population of children that have chronic migraine. These are people that have migraine more than 15 days out of the month. And another interesting point, or something else to point out that's different in children, is that prior to puberty, it's equal to find boys and girls having migraine. So I think, typically we think of migraine as more common in women, but actually in young children, it's either equal or even a little bit more frequent in boys. So what are some of the typical features of migraine in children, and how is it different than an adult who has a migraine? So in children, the headaches tend to be shorter in duration, so we typically, for adults, think that the headache for a migraine needs to be about 4 hours at minimum. In kids, it can be as little as an hour or even less than that, sometimes even half an hour. The typical features that we think of for migraine, like light and sound sensitivity, often don't develop until later on in the child's life. So, if you have a 7 or 8-year-old with migraine, they may not have that typical picture of kind of curling up into a ball and covering their head with a pillow. They may actually have more of the abdominal, like the stomach stuff, so they may get a lot more nausea, sickness to their stomach. Children often have a hard time describing the pain, so often we're looking for specific descriptions to diagnose migraine, and they oftentimes can't do that. And then one of the other things that kids will find is that their headaches tend to be not just on one side, but can be on both sides of their head. So my general feeling is that if the following symptoms are happening, it's probably a migraine. If the headache is causing significant pain, so moderate or severe pain, it's in one part of the head, so it can be the whole front, the whole back, or one whole side. If they are able to describe a pulsatile nature to it, and then if it's worsening or limiting physical activity, I think if any of those things are present, I think it's probably migraine. I just want to mention briefly, again, one of these big issues is identification of migraine in general, and particularly in children, and how we have such a hard time with it. There was a recent study that was done in the Journal of Pediatrics that looked at a new questionnaire base that was not administered by a physician, but by someone kind of trained in the questionnaire, so it can be done kind of not necessarily in the physician's office. And it looked at some of these core features that I just mentioned. On top of, in addition to that, they looked if there were any symptoms of aura, how often the headaches were happening, and importantly, how disabling these headaches were, how much did they interfere with their life. And it was was found that this particular questionnaire was very, very sensitive. It actually overdiagnosed migraine, which is in a questionnaire what we're actually looking for. So I think that there is hope that we're finding better tools to identify migraine and other types of headaches in children, that we're working towards a better understanding of what it looks like in children. And so this study, I think, is definitely a positive step towards trying to figure that stuff out. I just wanted to briefly mention that that concept of chronic migraine does happen in children. Up to the 3% under the age of 18 have chronic migraine, and over half, so 60%, haven't seen a healthcare provider about these headaches. These are headaches that they're having at least every other day, if not every day, and they haven't spoken to anyone about it. And less than 20% of them are taking any form of preventive medication, which we do think is important in chronic migraine. So this is really an underserved group. The other important thing to note is that adolescents that are experiencing chronic migraines, so having very frequent headaches, have a higher rate of experiencing some form of sexual abuse. So this is something that I think is really important for everyone to know, and I think needs to be screened for, obviously in a sensitive way, but as a parent also just kind of knowing that this is a little bit of a, if your child's complaining of a lot of headaches and we do decide that they're migraines, it's something that we need to explore. I also want to mention very briefly about some unique things that happen in children that are considered migraine variants. These are things that can happen in children that are prior, in a very young age, and they look very unusual and don't necessarily, most people don't associate them with migraine, and so it's helpful to know about them. In general, these migraine variants are called that because they tend to run in families where migraine is a strong history, and oftentimes children that experience these variants will go on to have migraine later in life. So, for example, this first one that you see up here, paroxysmal torticollis, what that means is torticollis is kind of a twisting of the neck, and you can see in the top picture up there a little boy with his head kind of tilted to the side. This can happen in young infants, several months of age to a couple of years. We'll look at these sudden episodes where their head will tilt to the side and then it gets better. Something similar to that is where you can get the sudden onset of spinning, and the child will mention either like not wanting to walk or being very clumsy, usually typically only for 5 or 10 minutes, but it will come and go. Another thing called cyclic vomiting syndrome, where children will have these kind of repetitive, very profound episodes of vomiting over and over again, but then in between the episodes of vomiting, they're totally fine. Abdominal migraine has received a little bit more, I think, notoriety, so people may have heard of it, where it's basically the same thing as a migraine, but instead of head pain, you get stomach pain. There's also these much rarer forms, including hemiplegic migraine, which means that one side of the body will go actually weak. You can't move that side of the body. It's a little bit more common in children. And something called ophthalmoplegic migraine, which is when the eye gets involved and actually the eye itself doesn't move. And again, kind of in this bottom picture here, you can see a child looking up and then the other eye isn't moving at all. So those are much more dramatic forms. But it's just to kind of point out that there are these things that we see in children that can be indicators to us that they're actually migraines. In addition to that, there's some other stuff that goes with headache and migraine in children that you may want to think about or you may notice in your child. It can go along with a higher rate of depression or anxiety. So these are things I always ask about, and I think it's important to notice if there are symptoms of those. Obesity certainly will increase your chance of having migraines, and as so much of the country is focused on the obesity problem, I think that this is just another thing that can be part of the symptom complex that comes with obesity. There can be a significant amount of sleep disturbance, and not just descriptions of not being able to sleep. Oftentimes children with migraines say they just don't sleep well, but they actually have instances where the children will have sleep apnea, where they stop breathing while they're asleep, which is something that does need to be addressed because it can have consequences. In addition, children with migraine often are more commonly prone to motion sickness. There's other kind of funny things that actually happen more frequently than we think, something called red ear syndrome, which is what this picture is on the right, where kids that get migraine also get these bouts where their ear all of a sudden will turn red and hot for a couple hours, possibly related to the headache and not necessarily always. And the same thing with the limb pain. They can get these episodes where they just get a really intense pain in their arm or leg with or without the headache. And we don't quite know why these are all linked together, but it's just something that if you've seen this happen in your child, it can be a clue that they also have migraines. In general, the prognosis is good in the sense that most of the time by kids get to the age of 25, at least a third of them, their headaches will be completely gone. But the bottom line is that migraine is a lifelong condition, and so it oftentimes can relapse later in life. And so learning to manage your migraine at an early age, I think, is helpful for setting you up for a lifelong ability to manage your migraines if they do come back. And that there is also some concept that potentially migraine is a progressive disorder, and that maybe by identifying and treating migraine early, not only are we helping the child's quality of life, we may be preventing further progression later in their life. Our focus in treatment, and I'm not going to do a lot here because my sense is that maybe we'll talk a little bit this as we kind of get into questions, but there's the main treatment options. A lot of what I do is focus on non-medicine stuff because I think that's really important. So I spend a lot of time talking about lifestyle modifications, regular sleeping and eating patterns, regular exercise, limiting caffeine, all of that. Also identifying potential causes of headache, I think, is things that trigger it, changes in weather, certain types of food, that kind of stuff. And then there are other alternative therapies that have actually been tested and proven to be effective in children. These include things like biofeedback, meditation, and cognitive behavioral therapy. There are certainly some vitamin supplements that I do also use in children. There have been many that have been tried. The list here are the ones that have been tried in children. I think probably the one with the best evidence is riboflavin, magnesium as well. I think the other ones have some positive studies and some negative studies. It's not as clear if those are helpful. And then we also have our rescue medications. These are medications that you take when you get a headache. First line, typically we use, there's over-the-counter stuff, things like ibuprofen or acetaminophen, Tylenol. But we do use triptans, which are kind of a lot of what we use in adults. And the important thing to note is that recently, so for a long time we were using all this stuff off-label, but recently 2 medications have been approved by the FDA for children. They're safe for use in children. These are rizatriptan and amitriptan. And then there are some other ones that have been used for a long time in children and we feel comfortable with. These include sumatriptan and zolmitriptan. And it's also, it's important to note with these, as an addition with other medicines, that they come in various different forms, that in young children, if they're not able to swallow pills, both using nasal sprays or these melt tabs or liquid in some of the other medicines is important because it can help get the medication into the child as opposed to being limited by their inability to swallow pills. And then just also we do use preventive medications in children. A lot of this looks very similar to what we use in adults. The only difference possibly is a medicine called ciprofloxacin, which I think is more exclusively used in children. It's an antihistamine like Benadryl. But I think that there are very safe, well-studied medications for use in children that have very frequent headaches, and it is something that we do use, and I use on a fairly frequent basis, and it can really make a big difference in the frequency of the child's headaches. So those are my slides. I'm going to stop there, and I'm happy to take questions from anyone about anything I talked about or anything else that you guys have questions about.
Oh, thank you. It looks like our first question comes from Brooke, and she'd like for you to tell us a little bit about stabbing headaches. Her 5-year-old boy was recently diagnosed with this. They're intermittent, but sometimes cause him to cry very hard, and it usually lasts for a minute or two, and then he's fine after that. She also states that her family has a history of migraine.
Sure. So stabbing headaches, there are lots of different names. There's stabbing headaches, they're called jabs and jolts headaches, or ice pick headache. It's all describing the same thing, and it's actually a pretty accurate description of what the person feels, which is this really intense, sharp pain. It usually lasts for seconds, up to a minute, so it's pretty short-lasting. And it can be anywhere on the head, so it can be in the front and the back. It can move around, and it can happen once or twice in a day. It can happen multiple times in a day. It can go several days without happening. It's a pretty here and there kind of headache. We don't have a great understanding of what causes these headaches or where they come from. We know that they happen much more commonly in people that have migraine. And so it's possible that if this child in particular has an experienced migraine, certainly with the family history and with this experience, it's possible that migraine may pop up at some point in the future. They're tough from a treatment standpoint because they're so short-lasting. Really, anything you do from medicine-wise, by the time you get it in, the headache's over. So if it's not particularly frequent or disruptive, we tend not to treat it. And the good news is that it tends to go away. It can be around for a couple weeks or months, but then it tends to kind of go away as quickly as it came, hopefully never to return again. So that's usually what we hope for. I mean, if they're really happening very frequently and becoming debilitating, there are medications that we can use, but we usually tend to try to shy away from that.
Thank you. Our next question comes from Alicia. Her 14-year-old daughter has been diagnosed with new daily persistent headache. She has had a headache 24/7 for the last 7 months. They've seen numerous doctors and they've had an MRI and all is fine. She's currently taking her 8th medication and it's not working. Alicia would like to know what would the next steps be? Like, what would your recommendation be at this point? They're seeing her miss a lot of school and also become depressed and feeling hopeless.
So new daily persistent headache is really, really, really difficult, as you've experienced. It's something that, part of the reason it's difficult is that we don't understand what causes it. So when we don't know the cause of it, it's hard to treat it. There are some theories that it's related to infections, but, I think that just as much people say it's not. It is a headache that will come on basically one day and last continuously and not go away, and the people really suffer with it because it's just kind of a constant presence in their life. It can be extremely disruptive. As far as other things besides medications, I think, and I'm sure that you've certainly talked with the specialists about this, trying some non-medicine-based approaches, especially if, I think if depression is or mood stuff is coming into it, as it, usually does. I think making sure that you have a good support system also with a psychologist, and focus on other forms of kind of alternative healing. I think that that's an important thing. And then, there are some other certain types of things we can do from an interventional standpoint. I mean, we sometimes do injections or we sometimes do IV medicines. I'm not quite sure, what she's received, but I think probably the more important stuff would be to focus on her mental health and having her as much as possible as interactive with her classmates and her friends and making sure she doesn't withdraw socially.
Thank you. Our next question comes from April. April would like for you to describe the difference between cyclic vomiting syndrome and abdominal migraines.
So I think that the main difference between the two of them has to do with the amount of vomiting. So cyclic vomiting syndrome is typically seen in a slightly younger age group than abdominal migraine. Cyclic vomiting syndrome is typically seen in like 2-year-old, 3-year-olds. Can actually happen even in infancy. Whereas abdominal migraine tends to present a little bit older, closer to 7, 8, 9-year-olds. So there's a little bit of an age difference. In cyclic vomiting, the vomiting is really, really prominent. So kids that have this, at minimum, should be vomiting 4 times an hour. And at times it can be even much more than that, up to 10 times an hour. And it's a repetitive, that will happen for several hours or days during kind of a period of vomiting. And then after that, they feel, they go back to their normal life and they don't have the vomiting. Abdominal migraine, the main component is this kind of nondescript, funny feeling in their stomach or abdominal pain that's kind of right in the middle around the belly button. So while they can get a little sick to their stomach, they don't really have the vomiting part of it. So I think, not only the kind of those differences, but also the age differences are the main ways that you can tell the difference. And oftentimes children will go from cyclic vomiting into abdominal migraine. It's kind of like a progression. And then eventually they'll develop migraine where they have head pain.
Thank you. Our next question comes from Kate. Kate would like to know if children have to stay on medication their entire lives.
Sure. So I think absolutely not. When we make the decision to start a child on medications, I think that it's not a decision that I take lightly. I think that this is a discussion we have because when we're starting medicine, it's not going to be an overnight thing. Most of our medications take several weeks, sometimes months to kick in. So certainly there's a lot that leads up to it. The medicines themselves, when we start them, we're expecting a child to be on it for a couple months or even a year. However, oftentimes if you're able to kind of really make a difference in the frequency of the headache, which is what we're trying to do with preventive medicine, is that those headaches will start to become less and less frequent. Well, they may not go away completely. They'll get reduced significantly enough. And we think that something eventually kind of resets in the brain, that the threshold for headache gets raised again. And so things that were maybe causing headaches during this bad period no longer will cause headaches, and that it's kind of like a brain reset. And so once that happens, we very frequently will take children off, or people in general off, and they're okay. They've kind of been reset. They may have a headache here and there, but they can use their medication, their rescue medication, and it works effectively. There are some children that need to stay on medicine longer than that, and the thing with these medicines is that the vast majority of them have been around a long time, and so we have a good sense of their safety and long term, and none of them are, we think they're all safe to take for several years. But I think always our goal is to try to get a child off medication once we've gotten their headaches under control.
Our next question is from Kim. What is your opinion of Botox injections for chronic migraine?
Sure. So I think we certainly have, Botox has been used for a while for migraine. I think that the fact that we have a lot of recent studies and data that have shown positive effects with Botox, I think that people have gotten, it's become much more popular and people are hearing about it a lot more, which I think is a good thing. I think my feeling about Botox is that it's only used in people that have chronic migraines. So these are people that have 15 days or more out of the month with headaches. So these tend to be people that are harder to treat. Oftentimes they've tried several preventive medications and have not been successful. And really the exciting thing about the studies that were done is that they were studying those people, so people that have failed multiple medications, that have these really notoriously difficult to treat headaches, and they still found that the Botox was helpful. So, and my general feeling is that that's true. I think that people that are in these situations that really have very, very difficult to treat headaches will find benefit from using Botox. I think that, it's not. I don't think it's the the be-all and end-all that if you use Botox that's going to cure you. Absolutely. I mean, I still look at it as kind of the way I look at it using any of the preventives. If this preventive is going to help you, we have to see. And it's the same thing with Botox. It's not a guarantee that it's going to help you. It kind of depends on how your body responds to it. But I think it definitely can be helpful in people that have tried multiple medications. I think I have seen certainly a lot of benefit in people that are typically having a great deal of suffering.
Our next question from Leslie. Leslie has a 13-year-old daughter that had migraine, her first migraine, that lasted 5 days. Tylenol, ibuprofen, and naproxen were ineffective. They tried steroids, and that seemed to break the cycle, but she would like to know what they should do in the future if it happens again. Leslie has a history of migraines, and the doctor wanted to try Loratabs for her daughter, but she didn't think that was a good idea.
So, these are certainly tough ones. These very, very long-lasting headaches. Typically migraines last for a couple hours. They get better when you go to sleep. That kind of resets it. But there are people like your daughter where they can really go on for days and days. And the unfortunate or the difficult thing about those really long headaches is that the longer you get into it, the harder it is for our kind of regular over-the-counter or our rescue medications to work. So what I would say is that the next time that she gets a headache, you really want to try to be aggressive about treating it, especially if she has a history of having these really prolonged attacks. You want to try to kind of catch it right at the beginning, because that's when you have the greatest chance of being able to treat it effectively. So, specifically if you had used some of these over-the-counter things, it may be time for her to try a triptan. So these are the things like I was talking about, like rizatriptan or sumatriptan, that will it can possibly be more effective than the over-the-counter, although really, honestly, the timing is the most important. So the second she kind of feels like the headache's going on, you want to try to treat it with that. You may want to use it in combination with the over-the-counter. It seems like you're kind of taking a lot of medication all at once, but that actually leads to you taking less medication overall. And so really what I encourage is, number one, identifying the symptoms that your migraine's coming, and then the better you get at that, the more, and carrying the medicine with you. That's the other big thing, is that you want to make sure you have it with you so that when it happens, when you're out on your weekend school trip, that you've got it with you so that you can take it. So that's where I would focus for the next time, is early treatment, and then potentially adding in one of these prescription medicines that can be very helpful.
Thank you. Our next question. My daughter's main trigger is when cold fronts come through. Are there any preventative medications that work best for that trigger, or are there other ways to decrease the trigger's effect?
Sure. So that's those are the tough ones, the triggers that we can't really control. And so there's no medicine that we can necessarily give her that will reduce her in that particular time frame. And so usually what I tell people for these kinds of triggers, the ones that are out of our human control, are that that's the time, if you know that there's a cold front coming in, that's the time when she wants to be extra careful to avoid all the other potential triggers that could make it more likely for her to get a headache. So that includes, those are the days when you want to make sure she gets enough sleep, that she's eating regularly, that she's really well hydrated. She may want to take, maybe that's not the day to try to load on, 3 or 4 extracurriculars. She wants to kind of try to take it easy, try to minimize stress as much as possible. If they're happening very frequently, if the headaches are often enough, we do use preventive medications to try to decrease that threshold as well. Typically what I say is, if you're having, at least 6 headache days out of a month, preventive medication is something that you can think about. So if she does find that that's what's happening, a preventive can help her with that. But as far as something that she would take kind of on the days when there was a cold front, I don't think there's anything specifically that would help. So it's really just that other kind of trigger avoidance and kind of just good lifestyle stuff.
Thank you. Our next question comes from April. What frequency of rescue medicines is safe without risking rebound headaches?
So it's a little bit different depending on the type of medication that you're using. The medicines that are more notorious for causing rebound headaches include the opiates. These are things like Percocet or oxycodone or hydrocodone. And then one of the combination medications that contains butalbital is things like Furacet or Furanol. Those are those tend to lead towards rebound headaches or medication overuse headaches pretty quickly. And so we try to limit it to no more than 10 days out of the month. And really, honestly, for those medicines, I really try to encourage my patients to really be even more minimal than that, because I do get very nervous about rebound headache. As far as medicines like the triptans, so these are the things like sumatriptan or rizatriptan, as well as over-the-counter anti-inflammatories, things like ibuprofen or acetaminophen. In general, my guideline is, 2 days out of the week, maybe 3 on a bad week. I wouldn't do it any more than that because while they're less likely to cause rebound, I think we think it still happens. And in general, if you're taking it that often, you're probably not going to be as effective, and we should probably more be talking about preventive medications. If you really have to use your rescue medication several weeks in a row, multiple times in a week, I think it's just, you're going to find it's not that helpful, in addition to you risking the chance of having a medication or a rebound headache.
Our next question comes from Dusty. Does gluten have an effect on migraines?
It's a controversial question. I think that we think that there is potentially a link between gluten intolerance and migraine. So these are people that are diagnosed with celiac disease. People that have known problems with gluten do find that they have, those people are at greater likelihood of having migraines, so that we know that there's a higher number of people than expected with celiac disease that also have migraines. And so those people find that when they use their gluten-free diet, that their celiac symptoms get better, and that can include their migraines getting better, having less frequent migraines. For people that are not gluten intolerant, so that have not been diagnosed with celiac, it's much less, so there is no evidence that using a gluten-free diet is helpful. There certainly are individuals out there who do feel like it's helpful. The thing with gluten-free diets is that they're hard to maintain. They require a lot of specific meal preparations. It can be a little expensive to try to find gluten-free food, although it's certainly easier than it was in the past. So I don't, in general, recommend gluten-free diets unless there are other symptoms of celiac, and then I would like the patient to get tested for celiac. And it's not really something that, unless there was some other particular reason that I have patients use.
Thank you. Our next question is, can you give any suggestions on how younger children can keep a headache diary?
Sure. So it depends a little bit on their age. I mean, they make a ton of apps now for the iPhone and for BlackBerry and Android. They have several of them. So for kids that are at least tech savvy to use a phone, those apps are probably the easiest thing because they have their phones with them all the time. If they're even younger than that, I think it's probably going to have to be based on reporting to their parents, and the parents going to have to keep the diary, which they can also do on their phone, or they can do in a traditional way. I think that one of the things that intimidates people about diaries is that a lot of the ones, even the apps that I've seen, can ask a ton of questions. And so, number one, if you have a headache, you don't feel like answering a lot of questions, and number two, if you're trying to kind of make this as minimally cumbersome as possible, and so oftentimes people get turned off when they have to answer 15 questions about their headache. I think the important thing to note is why we're asking you to keep the diary, and then I think you can kind of modify how you answer it. And really what we're interested in is actually the number of days that it's happening. So just making an X on the calendar is really the most important thing you can do. And then also focusing on kind of abnormalities in that past 24 hours, things like did my child get enough sleep that night? Did I skip lunch that day? Did I eat something unusual that I don't normally eat? Just kind of very basic stuff, and that's really what we're looking for. So especially for young children, I would focus mostly on just the having a headache or not having a headache, and then those simple lifestyle things that could, because we're looking for triggers, that could be potentially triggers. So I think by trying to simplify it, it makes it a little bit easier for the child to do, the parent to do. And then if you can get it on your phone, I think at least then it's with you, so you can just quickly tap a couple of buttons and you've got it in.
I think your next question is, are there tests to identify headaches specifically as migraine?
No, there are not. We don't have any. The way we diagnose migraine is through people telling us what they're experiencing with their headaches, and in addition to that, making sure that they have a normal neurologic exam, and that's really the best way to diagnose it. I think, one of the things that people are trying to come up with is how we ask the appropriate questions, because I think a lot of times people aren't asking the right questions to get the history of migraine out. So I think there will be hopefully some questionnaire tools that will help us diagnose it. There are some very rare forms of migraine. The hemiplegic migraine that I was talking about before, where there's weakness on one side, there are actually genes associated with that. So there are some genetic tests that can be done for that particular type of migraine, but for the kind of common migraine that most people have, there's no blood test, or there's no picture, MRI that you can do that will tell you that you have migraine.
Thank you. How would you treat post-concussive headache?
So it depends a little bit on, how long after the concussion the headache has been going on. Kind of in the immediate period after the concussion, we spend a lot of time focusing on kind of recovery, trying to minimize. Clearly, you have to stay out of any kind of sporting activity or things that are going to risk you hitting your head again, and focus on kind of minimizing stressors. Oftentimes we have kids take reduced workloads at school, or even, kind of come out of school for some period of time, minimizing, other kinds of other stimulation, lots of screen time, things like that. As the headaches go on, if they do last for longer than a couple of weeks or a month or so, we do wind up trying to treat them kind of like how they're how the child's experienced them. So oftentimes, the type of headache they're experiencing tends to be migraine headache, although sometimes they're tension-like headaches. And then we focus on treating them like a migraine headache. And so at that point, it becomes less important kind of what initially caused them, which was the head injury, and now about how it looks to me when I'm seeing them. So if it looks like migraine, I tend to try migraine medications and kind of other migraine interventions. If it looks like tension headache, it's the same thing. We try to treat it like a tension headache.
How can cluster and migraine be distinguished from each other?
So they're distinguished on kind of in a couple of different ways. The headache that comes with cluster headache tends to be a very specific type of, in a specific location, so it tends to be behind the eye, whereas migraine can be behind the eye. It can also be in other places. Cluster headache really only is behind the eye. And then I think one of the big differences is the length of time the headache comes. In migraine, headaches typically need to at least last 4 hours. In cluster headache, at most, they'll last, 2 hours, but in general, they tend to last much shorter than that, an hour. So there's a difference in how long they last. With cluster headache, they tend to be only on one side always, so they're kind of side locked. They're always on the left side. Migraine, it can move around. With cluster headache, there are usually other features that are very prominent, so that the side where the head pain is happening, the eye will tear, the eye will get droopy, the eye will get red, the nose on that side will get stuffy, the nose will run on that side, associated with the headache. Whereas you can get nose stuffiness and you can get some eye tearing or eye redness with migraine. It tends to be, probably both sides. It's not a prominent feature of the headache. And then I think then the other part with the cluster is that it will repeat itself. So you'll be fine, and then later on in the day it'll happen again. And it's a very different kind of the way people act when they have migraine versus cluster headache is very different. People with migraine tend to want to lay down, put their head under a pillow, sit in the dark. People with cluster headache actually tend to pace around. They get very, very upset. They're very, very uncomfortable. They tend to kind of run around the room or look very activated. And so I think, well, there's no, a lot of these things can overlap in general, especially if you're talking to someone that's, a headache person or at least, or a neurologist. I think the story is, when you ask the right questions, can really, can make it clear based on those symptoms.
Have you seen increased frequency of anxiety in children with migraine?
Yes, there I think is a fair number of studies that have shown that anxiety or depression or both of them are more common in children that have migraine. And then personally, just from experience, I think that there certainly is a higher rate of anxiety in people that have migraine or vice versa. And we also know that it kind of runs in families. In families that have more rates of anxiety and depression, there's a higher rate of migraine. And in families where there's a high rate of migraine, there's also people that have anxiety and depression. So they're linked in some way that we don't understand at this point in our scientific knowledge, but we definitely feel that that this is things that run in families and have some genetic component to them. And so I think that it's really important to screen for anxiety in patients. And because stress and anxiety can be a trigger for migraines, I think also it's important to identify that, because you may gear your treatment towards treating the anxiety. So I think it's it's a really important thing to notice. So I've been told that was our last question. So I hope that this kind of brief slideshow and this discussion has been helpful for everyone. I've been happy to be here, and I hope this was helpful.
Oh, I'd like to thank you for joining us, everyone. We'll send out reminders when our next webinar will occur. Looks like we're getting a lot of feedback here saying you did a great job, Dr. Babineau. Thank you for joining us, and I hope you can join us again in the future.